Hi guys, Tony RN here, helping you learn gastroesophageal reflux disease. When you study nursing, it's really helpful if you break apart words so that you know what these words are. So gastro is stomach, esophageal is your esophagus. So stomach, esophagus, reflux disease. So there's a backflow of your gastric and duodenal contents into the esophagus. The reflux is caused by an incompetent lower esophageal sphincter, pyloric stenosis, or motility disorder. When we have a patient with GERD, we need to make sure that there's a very thorough assessment. But when it comes to your nursing tests, they're probably going to focus more on the top 3 signs and symptoms that you will see. On the left side of your screen, everything is in black, which is your adult assessment. On the right side of your screen, everything is in blue, which is your infant or pediatric assessment. So let's look at the difference between our adults and our pediatric patient. So first we have pyrosis. Pyrosis is heartburn. Next, your patient will complain of epigastric pain. Now, whenever your patient complains of epigastric pain, you really need to rule out chest pain. Chest pain is an emergency. So make sure you ask your patient questions like, does it get better or worse after eating? Does it get better or worse with laying down? Once we rule out chest pain, we can be sure that the epigastric pain is related to reflux and not a cardiac issue. Next, we have dyspepsia, which is indigestion. Sialorrhea, which is hypersalivation. Occasionally, you will hear people also state that a patient is experiencing brash. Brash really is hypersalivation mixed with emesis. So we have saliva mixed with vomit. So like I said, sometimes you will see people chart brash. Again, it's just saliva mixed with emesis. Whether you chart it together or apart does not make much of a difference. Next, we have passive regurgitation or emesis. Occasionally, these patients will complain that they reflux, so there's no active process of them trying to throw up. Literally, gastric contents will just come up from their stomach, up their esophagus, and sometimes up into their oral cavity, into their mouth. Next, we have odynophagia, which is pain with swallowing, and dysphagia, difficulty with swallowing. So again, your top 3 assessments when we talk about GERD with an adult is pyrosis, your heartburn, epigastric pain, and dyspepsia, which is indigestion. Now, adults are easy, right? I mean, they can tell us what's wrong, they can tell us where it hurts, but infants really can't. So with infants, we're stuck more with having to do a very thorough assessment. Infants with GERD are going to be very irritable. They're going to have hematemesis, so blood in the vomit. They may have melena, and melena are really dark, sticky stools, and that darkness and that stickiness really comes from half-digested blood. If our infant has GERD for a long time or has a very severe case, you're going to see anemia from the blood loss. And we're also going to see poor weight gain. Okay, next, so what do we as nurses do? So what are going to be our top interventions? So one thing that we need to do is, if we think about reflux, you have gastric content from the stomach coming up and potentially going down the trachea into the lungs. So how do we know if our patient has that? How do we know if they aspirated? Well, our patients will start coughing. They will have dyspnea, difficulty breathing. They will start drooling. Now, if we see any of those signs, the coughing, the dyspnea, the drooling, what do? Well, we should really do a very thorough lung assessment. What are the lung sounds like? What is the pulse ox? And at this point, we're also probably going to look at our other vitals to see what the heart rate and blood pressure is doing as well. A safety thing that we need to always think about, if there is a potential that our patient will aspirate, we need to maintain suction equipment at the bedside so that we can intervene when our patient has that regurgitation and then aspirates. Also, we need to make sure that we maintain our intake and output. Okay, so next we have lifestyle modifications, or things that the interventions that mostly our patients should be kind of responsible for that we reinforce with teaching. Okay, so our diet. So our patients should really consume a low-fat, high-fiber diet. Now next, rice formula is in blue. Obviously, our infants don't have a choice as to what they eat. So we need to really make sure that we put rice formula into their food. And that's going to actually decrease the episodes of reflux for them. Another thing that we need to do, obviously, is tell our patients to avoid factors that decrease lower esophageal sphincter pressure or cause esophageal irritation. Okay, so what causes irritation? Well, there's actually a really long list. But I think some of this you can kind of guess. I mean, we've all gone out and late at night sometime had maybe pizza or something like that. And then we've kind of felt that whole indigestion, that uncomfortable feeling, right? So, tomato products, obviously very high on this list. Citrus products, spicy foods, fried or fatty foods, coffee, peppermint, chocolate, carbonated beverages, alcoholic beverages, or cigarette smoking. So we really need to advise our patient to decrease those items. Next, our patient should avoid eating or drinking 2 hours before bedtime. And this is obvious. If our patient is not consuming anything right before bedtime where they will lay down, there's less of a chance that they will reflux. Other lifestyle modifications that our patient can do is elevate the head of the bed. Obviously, the higher the head of the bed, the higher their torso, the higher their mouth, I guess, in relation to their stomach, the less likely they will reflux. Another thing that they should do is avoid tight clothing. Obviously, if somebody wears really, really tight pants, it's going to push up on that stomach and it's going to push up that contents. So if we can have looser clothing, there's going to be less of a chance of pushing all that stuff up. Okay, last we have those medical interventions. So what is our doctor going to do? Well, our doctor can order a lot of meds. So first off, we have antacids. Antacids are those over-the-counter products that a lot of liquidy products or a lot of chewable products that we see. Those are those calcium products, the aluminum products, magnesium products, which react with the gastric acid to produce neutral salts or salts of low acidity. We need to make sure that we educate our patient to not administer within 1 hour of other medications. Next, we have the H2 receptor antagonists and the proton pump inhibitors, which are going to be the more common type meds that we will see ordered. So the H2 receptor antagonists, a great way to tell those apart from other drugs is that they will end in tidine, so ranitidine, so your Zantac. And what do? Well, they decrease gastric secretions. The big thing to remember with these is to use them cautiously in patients with impaired renal or hepatic function. Next, the proton pump inhibitors. A great way to recognize these is they end in prozol, like omeprazole. Okay, so this is your Pepcid and stuff like that. and they're going to also decrease your gastric secretions. Next, we have your prokinetic medications, so your metoclopramide, your Reglan, and this you see mostly in the hospital setting, which will accelerate gastric emptying. So the thing that you always have to remember with this is if it's going to accelerate gastric emptying, moving in the stomach and gastrointestinal area, they're going to be contraindicated for mechanical obstructions, perforations, or gastrointestinal hemorrhage. Make sure you tell your patients to always avoid anticholinergics. They will delay stomach emptying, so we want to make sure that we speed up stomach emptying and not delay that. The other thing we need to tell our patients is to avoid acetylsalicylic acid. So this would be your aspirin products. We want to make sure that they are not going to consume products that are irritating to the stomach. Okay, lastly, we have surgical correction of our problem. This is obviously our last choice, and it's going to be used in cases that do not respond to medication. So what we have is we can do a fundoplication procedure, which is wrapping a portion of the gastric fundus, so part of the stomach, around the sphincter area of the esophagus. Some surgeons will also at the same time perform a gastrostomy, which is a surgical opening through the abdominal wall into the stomach to decompress the stomach after surgery so that the patient can more easily recover and not have excess pressure in their stomach or at the surgical site. Be sure to check out the key points notes page posted at the bottom. Have fun studying.